Okay, so hello and welcome to the OSA Alliance Virtual Roundtable, looking at coping strategies for a sleep and ventilation service for COVID and beyond. My name is Tim Quinnell. I'm past president of the British Sleep Society, and I'm a sleep and ventilation specialist based at Royal Papworth Hospital in Cambridge. And I'll be co-chairing with Jörg Steyer, who's current president of the BSS and based at Guy's and St Thomas Hospital, again providing a sleep and ventilation service down in London. So we are, the British Sleep Society is hosting this roundtable, but this is very much convened and organised by Gillian Gibbons on behalf of the OSA Alliance. And just a quick bit about the OSA Alliance. It is a loose association, but a strong association of the organisations whose emblems you see on this slide here. And it's a combination of clinicians and patient groups and others. And it was first convened in 2016 when, as probably most of you know, the EU directive on driving and OSA produced some challenges in terms of how they were translated to DVLA guidelines, which proved a bit cumbersome and unrealistic and problematic. So key members of the Alliance engaged and negotiated with the DVLA to produce a much more workable, pragmatic and realistic set of guidelines, which have, I think most of us will agree, have massively changed the lives of clinicians and patients alike in making them more workable. The Alliance was recently reinstated before COVID, partly because the guidelines, the DVLA guidelines, needed a few tweaks still to be engineered, and so we needed everyone back together for that, but also use the collective expertise and influence to look at other issues, chiefly continuing to try to raise and maintain the awareness of OSA among professionals and patients, and also to try to highlight the challenges that our services continue to face in a resource-strapped NHS. And this culminated in a document for World Sleep Day, which led to press releases and so on. And then COVID happened and dropped a bomb in everything, in all our lives, in the NHS and beyond across the world. And many of us will have experienced firsthand about our having to mothball our services, strip them down to the bare bones and provide only urgent access. There's also been the added sort of spin-off that CPAP NIV seems to have a role in acute hypoxic respiratory failure of COVID. And then there have been the other issues about CPAP NIV being aerosol generating. So there have been a number of things which have been very relevant to our services and our specialties, which have had their own impacts. So this roundtable is about experiences of how COVID has impacted us, but also now that we're post-surge and trying to get things started again, to share our experiences and ideas about how we do that. And also to use this as a learning opportunity to see whether we can take some good things from this and change our ways of working for the better. So we've got a great panel, which represents a mixture of, well, we're all frontline clinicians. Some are doctors, as in medical doctors, some are clinical scientists, but all very much at the coalface, with various other hats as well. And also geographically, representing quite a spread around England. I do note that we're not representing other countries, but I hope very much that we are representing the NHS and in the spirit of the UK and Britain. So without further ado, one housekeeping point. Some of the slides being shown by our speakers are to be shared within this professional meeting, so to speak, and they're not for publication or sharing beyond this. So I would ask that no one takes screenshots of any of the slides. Without further ado, I'll hand over to Jörg.
Yes, thank you very much, Tim, and welcome everyone. It gives me a great pleasure to introduce our first speaker on this panel today. He is consultant physician for the respiratory services and lead in the sleep services at the University Hospitals of North Midlands NHS Trust. And he has been involved significantly in National Society work across the BTS and the ARTP, of relevance in recent weeks. He has helped to write some guidance on the resumption of services in times of COVID. Now, Martin Allen, he is what is titled the Getting It Right the First Time representative for the respiratory and sleep service leads in the NHS improvement program. And Martin, you have prepared a couple of slides. I think no pressure, but you're worth your title now, Getting It Right the First Time. We all love to do this now coming out of the pandemic. Over to you.
Thank you, Jörg. That's guaranteed to fail, isn't it, when we start to share screen? But I will attempt to do that. So I've just got a few slides. These are, people can take pictures of them if they wish. They are going to be hopefully on the webinar subsequently. I'm just going to cover a few things about the problems we've got in sleep medicine. This will be no surprise to people on the panel and people who are on the webinar. I'm going to talk a little bit about the restoration of services, both in diagnostics and treatment, and perhaps just a little bit of a horizon scanning about what happens subsequently. So that's the kind of route map, if that's what we would like to consider. So what are the problems in sleep medicine? Well, pre-COVID, we realised that sleep medicine is unfortunately under-resourced. We have a huge backlog of patients, and one of the opportunities I've had during the Getting It Right first time is to go around and visit and discuss the nature of sleep services across England, and we have problems. Not only have we got huge issues about delays in people accessing treatment, but also even getting onto the diagnostics. And one of the major issues we've got here is around the staffing infrastructure to enable this to happen. And it is surprising how little both medical and especially technical and physiological time is dedicated to what is a massive service. And if we consider the number of referrals coming into sleep for many organisations, this is probably bigger than many services. And certainly we have more referrals into sleep than our colleagues have into diabetes and endocrinology. I just wish we had their 9 consultants. So I think we recognise there are problems. We also know that actually we have a fast track service to try and get people through onto CPAP who have critical, vigilance critical occupations, HGV drivers. Part of my GIRF visits have highlighted that we are not able to do that. And I think we need to make clear recommendations in the future to enable that to happen. So all this was going on, and then, as Tim has said, we got hit with COVID. And COVID, I think, has been especially problematical for respiratory services because it's a respiratory disease. And whilst a proportion of work has gone into critical care, the majority, 80% of patients with COVID in hospitals have been managed by physicians, predominantly respiratory. And that has been supported by our specialist nurses and our specialist physiologists. So the staff have been redeployed. And as a consequence, with the services closing down, we have a backlog. And that backlog is massive and growing. We do some 12,000 sleep studies, diagnostic studies a month. They have effectively ceased. We had difficulties, as I've already said, coping with the demand pre-COVID. How we get back to assess these 24,000 patients whenever lockdown really opens fully, I think is a problem that we are going to have difficulty addressing. And how we prioritise patients, I think, is something that we will need to consider. So that's where we are with the pandemic. But fortunately, in England, the UK, we're perhaps over that peak now, and the number of admissions is decreasing, the number of deaths, fortunately, decreasing. So the government have decided we need to get back to restoration of services, and there's documentation coming out from the public health and especially from NHS England improvement about how we restore services. So I've tried to look at that as restoration in diagnostics and restoration in treatment. So if we think about the diagnostics, how do we make a diagnosis? Unfortunately, if we are going to do a limited sort of sleep study, we need to get that to the patient. So is that couriered? Is that the patients come and collect it and we acknowledge that we need to have some element of PPE for around that? Do we think about going back to some older strategies and posting out oximetry to everybody? So I think how we start to restore the diagnostic services are quite important. But if we are taking kit to patients' home, there's an issue about how we clean it. And some of the things that may not have been disposable before may well now need to be. And there is going to be a turnaround time for that equipment to be cleaned. Our manager, when I spoke to her yesterday, had the idea of autoclaving all of our diagnostic equipment. So I think we have a little bit of education with regards to how we progress some of this. So the net effect of this is we've got reduced capacity in the setting of a backlog and a demand that we couldn't address previously. Polysomnography, multiple slit latency test. I think we're in a slightly different position there because if we are doing a PSG, we have very close proximity between the individuals, and whilst it's not a true aerosol generating procedure, if you're putting electrodes in people's hair round by their face and they cough, then potentially there are risks. So we need to take appropriate precautions. And of course, if someone has been in their isolated bedroom doing a PSG for 8 hours or so, and they are excreting virus, even though they may not coughing, there will be virus in that room. So we have to think about the number of air changes, how we keep that room clean afterwards, and again, protect our staff. So we've got a real issue about how we address some of the diagnostic issues. There are solutions. Some companies who are external providers from the NHS may find that they can undertake these services. So we may need to commission from the third party. Some equipment may be disposable. So I think we're in a stage of exploring lots of different equipment. I'd like to move now to restoration of treatment. And there has been some good things coming through this. Perhaps in the past, both our patients and our medical and clinical staff were reluctant to do virtual clinics. Was it really the same as talking down the phone than seeing someone? And I think there was a reluctance. However, COVID has meant we've changed. And there is a whole scale change now to remote and virtual monitoring that is going to stay. So I think from my activities, I've been doing telephone clinics. The patients are both appreciative and actually think it's better, especially those who need to travel a distance. So I think this is embedded and this is going forward how we will be doing work. There is an issue as we start to think about CPAP initiations. As I've said already, there is a big backlog. How do we do this? We know putting the mask on someone's face and turning it on is a potential aerosol generating procedure. So do we do a mask fit? Do we then let the patient go home? And at home, we support them with a phone call, with a sort of a webinar. Do we provide videos, but how to turn the mask on? And almost on a one-to-one remote, have a conversation about initiating CPAP. Do we do it with full PPE? And actually, we don't know. We don't know what patients like. We don't know what patients prefer. We don't know if this will work for the staff. And I guess if we are doing things different, we need to evaluate them because we are changing practice and we have no evidence. So it may well be that close contact, that one-to-one at the time of starting CPAP may not be there, and it may well be our long-term adherence to CPAP will fail. So we need to prospectively consider how we assess this. The final area is about CPAP follow-up, and I think we have moved dramatically here. Many organisations were doing some technology-enabled care through remote monitoring and assessing compliance, adherence with the machine, any problems with leaks, and then having a conversation with the patient. But that wasn't everywhere. And part of that was not having the equipment, but also that trusts were not allowing staff to do that. They were not signing off the information governance. And certainly that's happened very quickly. So this IG blockage for organisations has just melted away under the time of COVID. So I think we are in a different position there. However, we do not have enough CPAP machines that have the appropriate modem to enable this to happen. And this will vary across organisations. And some organisations will have lots of equipment that this modem remote monitoring can continue. Others, how's that going to happen if they don't have modems? Do we change and buy new CPAP machines, all of which are modem enabled? And what are the extra costs for doing that? And we need to be aware that, unfortunately, this does take additional time because the physiologists not only need to download and get a clear idea of the adherence and the problems with the use of the equipment, but they need to interact with the patients. So this isn't necessarily time saving. It does, however, and this is an important area, reduce footfall into the department. And therefore, close contact, social distancing, all those things which are really important from preventing subsequent transmission are enabled by this. We're having discussions within the NHS at a fairly high level about how we progress this, and whether that's buying additional equipment or actually adjusting the tariff or redesigning services, sleep services en bloc to ensure that there is an appropriate remuneration for doing this are ongoing, but we're certainly having those discussions. So I think we've got some positives which are coming out of our enforced restoration for CPAP. And in fact, we've held up this technology-enabled care as almost as a beacon of what we can do when we are enabled to do this. And this is sitting very firmly in the laps of the NHS England and NHS Improvement as pioneering practice. But what's the future? This will vary country to country, regrettably, even region to region. But we still know there are some 5,000 to 10,000 patients getting COVID per day. It isn't going to go away. And part of the issue we have in respiratory medicine is how we deal with subsequent surges. So whilst we're going through the phase of restoration, and staff, physiologists, medical staff, nurses are now coming back into the sleep service, actually there is a real threat that when we have the next surge, those staff will disappear again back onto supporting acute care. We also have the issue of nosocomial transmission. And whilst there is some variation in this, the data would suggest that as below, some 5% of healthcare workers are asymptomatic, and they're quite freely passing virus around. So there is an important aspect about the future of how we not only prevent the patients getting disease and transmitting it to other patients, but how we as healthcare workers do not give our patients and colleagues disease. And perhaps some interesting pilot work that's come out looking at the antibody test, and that has shown that 20% of asymptomatic individuals in one large organisation have antibodies. That may be good, suggesting that there is a lot of exposure that they're unaware of, but also reflecting that there is a large amount of prevalent disease. To cope with this, the government have come up with plans for how we start to restore things like minor surgery. And that involves the isolate and test procedure. And this involves isolating the patient and the whole of the infrastructure around them. So the children and the spouse for 14 days. They do not meet anyone. And then on 48 hours before, they have the test to see if they're virus negative. The evidence is that works, and some anecdotal responses from the north of England for cancer patients showed by following this, some 130 patients by isolating all were virus negative and actually could proceed with surgery, apart from one individual who tested positive, and he actually admitted he'd gone to the Lake District because he was so bored. So isolation does work. I would put it to you is, how many of our patients are willing to isolate to this extent for 10 days to come in for a CPAP or for a diagnostic test? So whilst this may work, how practical is it? So there are real issues there. If we think about how we test, the test is obviously for the antigen, and we're looking at using PCR tests. Regrettably, there are lots of issues at sampling. So some individuals will only have the sample taken from the front of the nose and not nasopharynx. So we fail to get the sample. We also may actually fail to isolate the virus. And it's worth just recognizing that there is a huge amount of virus shredding before people are symptomatic. And by generally day 9, when they may be starting to get some of their severe symptoms, actually there is very little virus that can be shed that's active. However, they may still be PCR positive for some 40 days afterwards. So we've got some real problems about using PCR, about its sensitivity and its specificity. We of course got the antibody test, and that has some problems. It does need a blood test, but it is incredibly sensitive and specific. So we're looking at over 85 to 90% for the 2 antibody tests that are available within the UK. So if we can shrink that down and make it near patient testing, so point of care testing, that may well be an advantage. However, the big problem we've got around this is we do not know if having antibodies actually protects. So having an antibody showing that you are positive for both the patient and the healthcare worker may not mean that you are either not going to get COVID or you're not able to be a carrier or a super spreader. So how about a vaccine? Well, I think we all hope that's going to be the solution, but I think we all know there's lots going on. There are over 50 clinical trials worldwide now looking at vaccine in phase 3, and hopefully something will appear, but when? We don't know. And I guess my final point on my final slide was just to say there is a lot of interest within central government about what has worked and what hasn't. So there is a national request that hopefully has been widely circulated, and perhaps we could put on the website afterwards, but if there is evidence of good practice and evidence that things have worked well, then we within central government want to know that so we can make subsequent changes and embed them. At which point I will stop sharing my screen and take some questions. Thank you.
Thank you very much, Martin, and thanks for summarizing this rather tricky situation that we are all in and that we are coming together here to find solutions for and exchange our experience, because that's what it's all about. We don't have all the solutions, we don't have all the answers, but just whilst we're waiting for questions from the audience to point out to everyone, we will take and read out questions if you put them onto the Q&A function at the bottom of your screen, and we will deal with them. We have plenty of time. So Martin, You've summarized it, yeah? We have testing now in place. We can have the PCR and we can see is the virus in the person. We can look at the antibodies. We don't know whether this provides immunity. And in the assumption that we have often actually a stealth virus flying unnoticed due to the lack of symptoms in many people, maybe across the community, how do we get back to these services? So the first question here from Chris Rogers, if I may read this out: do patients who have had COVID have post-infection immunity from their own antibodies? What do we know about this at the moment? What would we advise?
The answer, I think, simplistically is yes. The evidence behind it is quite limited. The best evidence is for places in, especially Korea and in China, where people were exposed to the virus, and subsequently, as lockdown has opened up, it appears that the re-emergence of virus, re-emergence of infection has not happened. There was a slight concern in Korea where 50 patients who'd had coronavirus and got COVID were said to be reinfected, but that paper was subsequently withdrawn. So it looks on the evidence that if you've had it, you are probably immune. The difficulty is that no one has quite been brave enough to, those individuals who've known they've got it, had antibodies, have then directly exposed themselves to see if they are immune. And the problem we've got, and it's the same as in the antibody, we have no idea about the duration of that. I would remind people that the coronavirus is the same as the common cold, and unfortunately we get lots of antibodies to the common cold, and unfortunately we continue to get the common cold. So we just don't know about the protective effect of these antibodies. And as I said, we don't even know whether it will mean that you do not get ill, but you then become super spreader. So there's a lot of information we don't know about the utility. And that is one thing that's been pursued, is the more people that get antibody tests, and then the potential, do they get COVID, will allow us to answer some of those questions. And as you realize, this is a very rapidly moving field.
Yes, you're absolutely right. And may I just add also my own experience that the course of events is, of course, you first contract the virus. Some of the strains seem to replicate more in the pharyngeal area, some more in the lung. So depending on where you take the sample from, sputum or pharyngeal swabs, you might not get positive tests at that stage. Then the seroconversion, New England Journal article last week actually says the seroconversion from IgM and IgG is roughly around the same time, within 2 to 4 weeks. But that doesn't indicate necessarily that the virus has cleared by then, particularly if there's pre-existing lung disease. Some patients might not have cleared by the time of the seroconversion, the virus. And there are series reported in our case series where actually people have the virus, the PCR still positive for 4 weeks easily. Yeah. So at what stage is this getting into the kind of phase where we say the patient has cleared the disease and is not infectious anymore and has got immunity? We do not know this all yet. But no, thanks for summarizing this so far.
I just to respond, of course, as I've said, the difficulty we've got is the PCR is very sensitive and it will continue to pick up viral particles for several days, up to 40 odd days subsequently. So I think the difficulty we've got is that recurrence of infection? Is it continued infection? Or is it just viral particles that are hanging around? And it seems a really simple question and a really simple answer, and we can't do it. And that's why we've got some variation in discussions about lockdown. When you've had it, do you isolate for 14 days, 10 days? People are saying, is it now 5 or 7 days? And that, unfortunately, I think produces the confusion because we don't have the evidence, despite what we said to be following.
Okay. Let's move on with the questions. Richard Kumarasina asks, what is the turnaround time for the sleep testing equipment? And this is, I assume, when you send out equipment into the community and you need to take it back and sterilize it or clean it. What is your experience and guidance at the moment, Martin?
I think this will vary because, as we know, the virus will live or is reproducible on different surfaces at different times. So that's part of the difficulty we've got. We're generally saying that we started off isolating all of our equipment for a couple of weeks, and the reality is that's just not tunable. So when equipment comes in, we're wiping it down with appropriate virucidal solutions as much as we can, and then we're isolating it for 3 days before we are then attempting to consider it to posting out. I think if we are able to leave it longer, we will do, but as we start to get that turnover, we need to think about that minimum time.
Excellent. Adrian William asks, Martin, agree wholeheartedly, virtual clinics work and there are no DNAs. And oximetry is underused, exclamation mark. But perhaps more home testing, even near PSG equivalent, for example, watchpad for some questions of, for example, sleep state misperception and slow wave arousal disorders could be used. What's your latest on the recommendation of wearables for home sleep studies, Martin?
Yeah, again, when we put the document together, we recognize that this is an evolving area. And I think I did mention that we've got some equipment such as the watchpad, which is disposable. So I think the environment of which we work is changing, and that may be one option. I'm slightly old-fashioned. I've used oximetry for many years. And I think in a skilled individual who's used to interpreting it, there is a great utility for certainly identifying those at high risk who need to be seen. I guess if we start to go down the PSG route and for home PSG, then we do have problems about failure rate, and then we still need to look at the appropriate cleaning and sterilisation of the equipment afterwards. But our real pressure, I think, is around the number of people with sleep apnea and those in the vigilance critical occupations that actually have got the issue, can I drive, can I go back to work, can I do all the appropriate things? And that's really quite difficult, I think, to how we get those through the system.
Thank you, Martin. And one final question here, because we need to move on to the next speaker. We will have all your lovely questions, the chance to respond to them later in a long roundtable discussion, but we have a couple of onward commitments of Martin and Brendan Cooper. Thus, at the moment, just the last question, a very relevant one from Sari Sutherland. Martin, to you, how are other services currently prioritizing their backlog of patients? Do you have any insights from your connections across the NHS?
Well, we could spend the rest of the afternoon talking about how different specialties perceive that their backlog is more important than everybody else's. Where we are, I think, is a real difficulty because many services are going back to, as I said, the 14 days isolation. So we're starting to re-establish that. I think that is important because, regrettably, if individuals are both peri and post-operative who develop COVID, their outcome is really quite poor. So there is an increased morbidity and mortality of acquiring nosocomial COVID post-operatively. If we start to look at some of the other services, they are thinking along similar lines, but they aren't in such a worse position as ourselves because their staff have not generally been deployed so much to the front line. And as we said at the outset, and Tim highlighted, such a lot of our physiological staff have been supporting CPAP on the wards, and that's not been perhaps such an issue for other areas. There is a lot of work going on in the Royal College of Physicians and within the Department of Health around the restoration and the prioritisation of different areas. The final point I would make is for respiratory medicine and to a certain extent cardiology, we have a real issue about how we reinstate radiography. And this is true for CT scanning. And as we appreciate, I perhaps consider it as a double whammy. We've got a real difficulty about instituting respiratory physiology because of the AGP that is. And we've got the problems about a dramatic reduction in CT scan capacity. So we have a backlog of patients. We have a whole cohort of post-COVID patients that need to be followed up, many of whom will need a CT scan. At the time, our CT capacity is at best a third of what it was beforehand. So I think the NHS has got some real issues. We are trying to address those. There's issues about increasing the number of scanners and trying to put scanners in clean areas to enable that to happen. But this isn't an easy solution. And as we've said, in the light of endemic COVID, this is going to remain with us for several more months to years.
Martin.
What a depressing note.
Not at all, not at all. We got to start somewhere. And at the moment, a lot of what we find in terms of solution is helpful to give us confidence to do the right next step. So we got to take this slowly, but just like in activities of everyday life and getting children stepwise back to school, we got to find our confidence back to make this happen safely. So thank you very much, Martin. And thanks everyone for their questions. We can leave them up. We can come back to them at a long roundtable discussion later on. But I continue now and hand over back to Tim to introduce our next speaker, please.
Thanks, Jörg. Well, it gives me a great pleasure to introduce Professor Brendan Cooper. And now Brendan is qualified to be a member of the OSA Alliance or to represent the Alliance with at least 2 different hats. Well, 3 probably. He's definitely a frontline senior clinician. He's a consultant clinical scientist at the University Hospitals Birmingham, and he leads the lung function diagnostic and therapeutic team there. And I think that's evidenced by the fact that we're seeing Brendan in between 2 night shifts. So he's very much at the coalface. He also was the long-standing chair and subsequent president of the ARTP. And now he's the first president of the Academy for Healthcare Science. So I'm sure Brendan has a lot to tell us about. So over to you, Brendan.
Thanks, Tim. Can you hear me?
Yes.
Yep, good. Okay, so I'm wearing glasses, and when I was at school, people would call you 4 eyes for wearing glasses. And I'm going to mention 4 eyes that are very relevant to this discussion on COVID. The first eye was as we went into this whole thing, and very relevant to what we're doing, was the information overload. From a kind of a professional body's point of view, NHS England, it got very, very complicated. And so the ARTP worked very hard to get accurate, clear, correct information in terms of guidelines on what you should do with your services. So when people were switching from normal service to decrease the footfall in hospitals, we went over, of course, to virtual clinics, phoning patients up, remote monitoring, and all the stuff that Martin was telling us about just now. Absolutely incredible change. Something which, again, Martin alluded to, was going to come for the long-term plan. But of course, we've been able to do it because of this catalyst that COVID has been. So the information, and I think the most critical information, moves on to the next eye, is infection control. This disease is a very complicated disease. We thought to begin with it was a respiratory disorder, and we very soon realized it's actually more of a vascular disorder and therefore multi-organ involvement. And we've seen many, many patients who've come to hospital suffering the consequences of that. But the infection control has dictated what we've been able to do and what we're going to be doing in the future. And again, Martin's alluded to this very nicely. So infection control has been very, very difficult in this because we've come into an area of science which doesn't have the same approach as we always have to things like, randomized controlled trials isn't actually possible to do, and lots of other scientific method that we're very used to as physiologists and physicians. We're not seeing that with infection control because it's not physically possible to do all of those things. And it's also quite difficult to interpret them. And so you end up with a situation when you go to infection control professionals that in different sites around the country, you get a different answer. And this has been very difficult from a professional body point of view. We've seen emails from individuals who are not prepared to go and do, I'm thinking of lung function, but this would also be true for sleep and NIV services, not prepared to do certain activities because they don't have the PPE. They're told to have a very basic level, and we know CPAP, NIV are aerosol generating procedures. AGPs we never seem to talk about before COVID, and now we talk about it all the time. And it's this infection control issue that is determining when we all open up our outpatient departments, when we do open them up, how we actually run them. It is not just even down to, you know, if we do have to set somebody up temporarily on a CPAP to see if the mask fits, it's non-vented, there's no humidifier. It's actually quite a long way from what they're going to experience at home. It's really important that we get these pathways sorted. And then there's the actual physical pathway of entering the hospital in a safe way, coming into a department if you're doing face-to-face, or maybe if you're just handing over equipment, some way to do that. I've just got to plug in my phone because I'm getting low battery. I do apologize. Oh, the joys of technology. Bear with. Okay, so I hope I'm still there. Yes, I'm still there. Right, so the infection control issues are determining how we're going to open up either our services in our hospital or, and one of the other eyes, which I was going to come on to last, but it actually comes in a bit earlier, is this innovation. We are now going to have to work differently, partly because of this COVID pandemic is forcing us to do it, and partly because we were heading in this route anyway, of the days of people coming to a hospital for a simple or complex diagnostic may be limited, and may be limited to a very few specialist tests. It's the location of where we do things is going to change, again, as Martin has mentioned. But we need to think of it, it's not that we are offloading diagnostic and therapeutic services, for example, sleep studies and CPAP treatment, just into the community. Yes, the location's in the community, but we're moving the staff responsible for doing that currently to work in those situations. So it's not an offloading of hospitals, it's a relocation, repurposing of what we're doing. And if there's one thing we've all learned about COVID, it's repurposing. We've seen our staff supporting ITU departments, joining ventilation teams on wards, donning and doffing, helping with all kinds of different ways. And we've actually realized that as a National Health Service, we're very good at working together in a new way. We've really learned something we used to know. And I think over time, we've become a little bit more specialized. I'm not going to say the word silo, it's not like that, but there's been a tendency to being so specialized that we don't think wider all the time. Some do, some don't. So this infection control issue is going to determine how and where we can actually deliver our services. We know that, from what Martin said, we've all been using PPE, and 20 to 30, I've even seen figures of 40% of centres where people have been positive to the antibody, suggesting that they have had the infection and are asymptomatic. So it is getting spread around. We think our PPE is good, but we haven't got it very bad ourselves, perhaps, but that isn't a guarantee. And I think the other area that the other I was going to mention was inspirational. It is the way that we have, first of all, changed the way we operated and repurposed. That was inspirational. Changed the way that many of our staff have worked with patients. So not having to do face-to-face, having to use either the phone or sometimes Skype video conferencing like this has really made people develop new skills which they probably didn't even know they had before. And certainly some of my technology skills, well, they could be better, but they have developed a little bit in all of this. But it's been inspirational the way that what we've done so far, I think will drive us on to meet these new challenges. There's no doubt about it. Our departments think differently, the staff think differently, and I believe our patients are thinking differently, because when, as Martin said, you phone people up, two things happened. One, if it was a few months into the pandemic, people have been self-isolating, you couldn't get them off the phone. And then secondly, the sort of patients, I think, have altered their expectations. Certainly people who are diagnosed and sorted were very much, no, look, I'm not using my CPAP machine. You can have it for patients on the ward. No, I'm not going to, ask for any more masks or anything. It's more important. And they've actually altered their expectations in a way. And whether that's a good thing or a bad thing, you could argue. But I think our patients are, in a place now where they're not feeling they always have to come to the hospital to get help. They can be informed by, video links, by YouTube, by lots of innovation and technology, which we thought, oh, elderly people, they won't be able to use this stuff. Yes, they can. I mean, most powerfully I'd seen that is on a COVID ward, a patient in her 70s who was Skyping with her family at sort of, 2 o'clock in the morning. She just was feeling very bad, and then utilizing her iPad. So this illusion we had in the past that people can't use this technology, I think it's only a minority can't. And we really need to get the bulk of our patients to use these ways that we can work with them. We can send out things, either have a delivery service, use the manufacturers directly to deliver to people. As Martin said, private sector of healthcare could be involved in this, or we could actually develop it out the NHS ourselves. And things like click and collect, we've seen this in our purchasing, because we don't go to supermarkets at the minute or go to any other shops. So this idea of click and collect your diagnostic test, your CPAP, your mask, and or if it's difficult for people to come out of their homes and they don't want to come out of their homes because they're self-isolating. And of course, there's postal services and courier services and all the rest of it. So it is a very dramatic shift in our innovation, coupled together with all these other changes. I don't particularly want to go on in any greater detail because I think Martin's covered a lot of things and there are other people to speak on this. So I'm happy to take any questions if necessary.
Thank you very much, Brendan. And it's good to see you in between your sleeps. So there are quite a few questions coming through. One common theme is about dealing with diagnostic equipment. This thing about isolating for 72 hours and so on. Several people are saying the same thing, that their hospital infection control teams are saying they're not worried about quarantining. They're saying it's fine to just wipe down the equipment with alcohol wipes and so on, and then they're good to go for the next patient. What are your views on that? And perhaps we can ask Adrian as well to give his views after that.
Yeah, I mean, my understanding, and that's the other thing, is I've done so much reading on epidemiology and infection control. I've kind of beginning to get a different picture of things. My understanding is that all the early evidence came out from PHE that, on different materials, it lasted for 20 hours, 72 hours, or whatever it was. Stainless steel, plastics, and all those things. I think that if we look at that in detail again, all that means is there is traces of the RNA of the virus there, not necessarily that it is actually going to infect people. And the infection control people are always sort of, one of the reactions I got, and I got into a bit of a spat on social media with some, was, look, you lung function and sleep people, you're getting all het up about this. Why didn't you worry about this 6 months ago, 6 years ago, 16 years ago? You know, just because it's this virus and we don't have a vaccine and any good medication, suddenly you've changed your own antibodies to infection control, and you're wanting to actually, you know, have all these barriers in place when it may not be totally relevant, or not relevant, but required. But I think, as Martin said, you know, it's early days. We're learning about this virus. We're learning, you know, some viruses wipe out within 10, 15 minutes. They've got these times for this now, but, you know, who does the infectivity test and actually check that if I go and touch that table, I get the virus if I scratch my eye or whatever? It's a tricky area.
Yes, indeed. And Adrian, do you have any comments on that?
No, I echo very much as to what Brendan has said. I think that it is probably better, whilst we are still learning about what this virus is all about and what it can do to us, to marginally err on the side of caution. That's been my approach, and I think that should be the approach that we should be taking. Once we get more evidence that is sound scientific evidence, then we can begin to move forward. And I think it's getting that evidence so that we, as a group of practitioners, feel confident that what we are moving towards actually is safe, not only for our patients, but also for the staff that handle that equipment when it comes back from the patients. So I err on the side of caution, but let's get the evidence.
Yes, that sounds very fair. And there's a question from John O'Reilly, who we know well, many of us, for the two of you. Should we run a trial to evaluate the efficacy of remote video internet CPAP setup and compliance assessment to support data showing good results for AHI leak and compliance outcomes? I think.
Yeah, there's been a lot of, you know, certainly abstracts and a few papers on this, of remote monitoring. Is John actually wondering, meaning the whole picture of the whole remote clinic or consult? I haven't seen any sort of trial of that. I don't know if that's what he means.
It's difficult. I mean, I think there were so many factors here to evaluate, so I think it's a broad question. But
I think that from a pragmatic point of view, the technology seems to work. In the early days, people were more obsessed about, oh, if I use remote, do I save staff time and workload and blah, 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 blah. Whereas where we've been now is, am I getting to see my patient and keeping them on their treatment adequately? And it's a much more light touch, because the danger is you can end up using just as much time as you would on a face-to-face. And I think we need to actually use it to cut things down so we get through this huge backlog that Martin's mentioned. We really have to be light on our feet with this, I think.
Thanks, Brendan. And a different question for Adrian. Given the backlog of patients for sleep diagnostics, have you changed the way you categorize respiratory sleep study urgency differently from pre-COVID? And do you initiate CPAP on patients without diagnostics in any groups, for example, HGV drivers?
Okay, so I do the majority of the triaging for our department. The only thing that I've learned this week is that priests are classified as key workers, and therefore should be classified as urgent. I didn't know that either. We do categorize people who drive for a living, and we've certainly had some new people who have become van drivers so they can deliver food to people, who we have put through as urgent cases. We have not set up anybody without screening oximetry, which we always do as standard in our department. We're still doing that, and we are still able to more or less turn people around in about a 2 week to 3 week period. We try to aim for 2 weeks ideally, It's got a little bit longer, and that's not because the team can't cope. That's actually more about the postal services and the courier services. And I have to say, to some extent, patients thinking it was okay to keep hold of the diagnostic equipment and somehow trying to work out how we were going to be able to analyze it whilst they've still got it. So there's been a few teething problems, but I think the only group of people that I've not classified as urgent is the odd airline pilot who is currently not working. Other than that, no, and also setting up CPAP trials, we are sending the equipment out. We have an excellent team of physiologists who are talking to the patients, talking them through the setups, and we seem to be having with our app-related CPAP machines generally great success, except in those not very tech-savvy patients that seem to be unable to understand the concept of Bluetooth. But I would say that's a small minority of patients.
Okay, thanks, Adrian. So just a couple of comments as much as questions from two participants before we move on. So Vicky Cooper has said the way they follow up their CPAP patients, so the follow-up, is they send an essay in a questionnaire and ask the patient to send their memory card. So obviously have that kind of set up. And they send a spare memory card to put into the machine. And then they call the patient when they've got all that back. If the patients don't send back their cards and questionnaires, they still call, but they don't send out supplies until they've received the card as an incentive to send it back. So that's an interesting way to do it, but apparently it's working reasonably well so far. They've done it since lockdown. They've not cancelled any annual review clinics, and their contact rate is probably higher than their clinic attendance rate. And Lizzie Hill, it's almost a rhetorical question. How do we trade off the immediate infection control benefits of disposable equipment against the environmental impact in the longer term? And I think we could have a whole session about that in its own right. But it's something just to consider when we're looking at the benefits of disposable kit in all that we do. So thank you to Brendan, Adrian, and to Martin. You're very welcome to stay on for the rest of the session, but I do know that all of you may have commitments to either go to work, go to another meeting, or go to sleep. So feel free to leave or to stay whenever you like, but very many thanks to all of you. Now the next bit, perhaps I'll leave. What we've decided to do for this is our three panelists remaining to speak are going to run this all as one. And so I will introduce them all at once. And in no particular order, we have Annabelle Nicol, who leads the Sleep and Ventilation Centre service in Oxford at the Churchill Hospital. We have Sonia Craig, who does the same at the Aintree Hospital in Liverpool, and Sophie West, who does the same from the Freeman Hospital in Newcastle. So all very welcome, and over to you.
Thank you.
Decide who starts.
So
Thank you, Tim.
I'm going to start sharing the screen. So we've put together a presentation, some of which we've discussed a lot of this already. So it's really just our viewpoint of what we're trying to do in our different services. So it's not necessarily the right or the wrong way to do things, but it was just our views on these things. So I think Sophie's going to start with. Sophie,
yes.
Is
my screen shared?
Okay, brilliant. Yes, thank you.
Okay, thanks, Tim, for our introduction, and thank you very much for the invitation, and to the OSA Partnership Group and Gillian for putting this together. As you can see, we've had different forms of PPE from the different regions we work in, and we're all very impressed by Oxford's PPE. One of the things we wanted to bring was how our services have adapted, and some ideas really up for discussion. But a recent conversation we had as a group raise the point that as much as possible, it's really important not to compromise the quality of the sleep services we're delivering to our patients. And that's something I think we do need to just bear in mind, that we're ensuring we're delivering good and accurate services of high quality. May I have the next slide, please, Annabelle? So I'm going to deal with new patient assessments and sleep studies. Annabelle will talk about CPAP and Sonia will talk about follow-up. So I know I'm preaching to people who, or not preaching, talking to people who are already doing this and have probably done a lot more than I have in recent times as I've been on a COVID ward. Having come back to the sleep coalface in the recent weeks, the question is about telephone consultations and who are the few patients who need a face-to-face. Telephone consultations, I have to say, in our team experience, have been quite an efficient way to deal with a lot of patients and avoid the need for them having to come to hospital at times when they definitely don't want to come out, and there are clear practical implications in the outpatient service. I think on some of the letters you receive, it's clear that a phone consultation isn't going to work, and I'm not going to prescribe who I think should be face-to-face. Someone who needed an interpreter and had hearing difficulties was an obvious one in the last pile I looked at as someone who should come to the clinic, but I think that will be individual assessment. I think it's very useful on a practical level if they have an appointment time, because they tend to be by the phone then and be in the right mindset. So if those usual clinic times can be stuck to, that makes our life a little easier. In terms of what tools you use to assist your consultation or standardize, I suspect for many people these will be the same as they were used to using in the sleep clinic. We certainly have a sleep clinic pro forma to use, and I think it is good to stick to that so that one isn't underplaying or undercutting what we normally do in the face-to-face clinic, because the cues are also slightly different you get over the telephone, and we want to make sure we're doing a full assessment. But I think those will change according to what you've been using in your centre. Who does the consultation? Again, I feel strongly this should be whoever normally does the consultations. And I personally don't think just because we have a bigger backlog, we should change who does this, in that I think this should be a skilled sleep professional who has experience and has training. That's my opinion. We can discuss that, I guess, if other people have different experiences. We have found it helpful when booking the clinic appointment to send people a questionnaire, perhaps to just focus their mind, but really an Epworth Sleepiness Score to have done and have the answers by the phone, because it gets quite tedious reading that out a lot of times during the afternoon. So just again to make it as smooth as possible when you have your phone consultation. I've highlighted the next points. These are things we would have usually measured or access to in the clinic that I would routinely use in a patient ISS that we can't easily do over the phone, or we can't do over the phone. The BMI may be in their GP's letter, the neck size may be. They might know their neck size, particularly if they're men buying shirts, but we aren't measuring that. Oximetry for their daytime saturations we can't do. Blood tests may have been done by the GP, they may not have been done, and I think that's one of the things we don't want to miss, the people who might have thyroid dysfunction. We also can't check a venous bicarbonate, which many of us have been doing as an assessment of obesity hypoventilation syndrome. And so it's just a flag that I think we need to say in a letter, I haven't seen their blood tests, or have they been done, and just as a way of making sure that isn't missed for these people, to make sure they're getting the same quality of service as they did face-to-face. We've touched on prioritisation already. We, in our discussion, felt that the two groups really were the sleepy vocational drivers who are currently working should get the highest priority of the drivers, and those who are at risk of hypercapnic respiratory failure, such as those patients with likely obesity hypoventilation syndrome, would be those we wanted to prioritise. May I have the next slide, Annabelle, please? So in terms of sleep studies, these have been discussed already. I won't repeat things, but just different approaches have been. In our trust, we have been given access to couriers via pharmacy courier service, which we haven't used previously, but we've started using. We'll report back, I guess, on how successful that has been in due course, but it seems like an operational system that already exists. We have used post to some extent in the past, particularly for oximeters, and others may have more experience to discuss of that. Oxford has been using a drive-through service where apparently the sleep equipment is put through the back window onto the seat with minimal contact. I guess you need to have the right car park facilities and available staff to do that, with PPE advice as well. Clearly, the less face-to-face interaction there is with physiologists or sleep nurses, you need very clear instructions. And I'm grateful to my sleep team in Newcastle for having put together these, and I've attached some of them on the screen. We are very happy to share these so that other people don't have to start from scratch. So do please email me, or perhaps we'll combine them all with the British Sleep Society that other people can access them. We've made full use of all the available YouTube films for patients to access. As people have said, there is a much slower turnaround than the giving it out in clinic, get it back the next day. And so you ideally need extra kit, or to use all the possible kit you have, and ideally to have this supported by managers and have funds to purchase extra kit. Back in the days when we were hoping there would be new NICE guidelines for sleep disorder breathing out on November the 5th, and they will still be coming, folks, it's just a slight delay. We had spent a lot of time reviewing the question about respiratory polygraphy versus oximetry, and clearly centres already have practice on this. I don't want to be a big spoiler alert person, but when we reviewed the evidence, found that oximetry was very useful in those people with a high pre-test probability of obstructive sleep apnea, where you didn't need other channels. So I guess people with obesity, sleepiness, a classic history, oximetry is adequate for that group, is what the guidelines will likely say. But those where there's clearly a diagnostic question need multi-channel respiratory polygraphy, but that may influence what people can do in this period, particularly if they have postal services which can use one and not the other. Cleaning equipment on the return, I think, has been discussed. Throwing the nasal component away, Clinell wipes for the hard bits, and Actichlor for the bands. Just to touch on inpatients, all trusts will have rules. These rules are different. In our trust, they need to be self-isolating for 2 weeks before admission, and then a swab 72 hours before the procedure. So quite a commitment from a patient. And this has led me to go through our inpatient list and really rationalise it where possible. Of course, some people will need polysomnography, that's the right test, and in which case they're going to need to commit to this, and we need to commit to give them beds. But I do think there are other patients where we can try a home study first and perhaps only go on to an inpatient study if we don't get the answer. Bed limitations are probably in common with everyone. We have fewer beds on the ward, fewer beds in the cardiothoracic directorate, and we need to share these with cardiologists, thoracic surgeons, etc. And there's a prioritisation process, and I don't really know how sleep falls down in that, and I think everyone's still working that out in the sort of bidding process of priorities, but it's just something to flag that I think if there are alternatives, that's preferable. That's all from me at the moment. Thank you. Over to Annabelle.
Super, thank you, Sophie. And thank you very much, Martin and Brendan, for giving us a fantastic highlight of an overview of COVID and how this has affected our sleep and ventilation services. What I'd like to do is to really talk about the different approaches that are available for setting up CPAP as an outpatient, and just sharing some data from Oxford. So before COVID, we were setting up 28 patients per week on CPAP. During the COVID peak, we were setting up a measly 6 urgents per week, in part due to keeping people safe and not bringing them into hospital, and partly because our staff were often redeployed to the front line. So where did we start from? This was our traditional approach with a face-to-face one-on-one consultation. And then we had a 4-patient group set up where the patient was usually accompanied by a friend or family member, which we thought was really valuable. And then the CPAP would be tried with the patient lying comfortably in bed with the support of a nurse and a CSW to help them with their mask fit. Fantastic personal patient contact, engagement, tried and tested, but obviously now that's a no-go due to the COVID transmission risk. And of course, we were in a real fix in Oxford with inadequate parking and travel times. So as Sophie has highlighted, we moved to phone consultations. This has gone quite well. They were ad hoc without fixed appointment times, and that's worked because people have been at home on the whole. So the flexibility was great. There were no DNAs. However, from my point of view, flexible work often gets displaced by other activities, and it's impersonal. So what are our options for them going on to set up CPAP? Well, when it was urgent during the peak COVID pandemic, we set up a small number of patients, one-to-one, face-to-face, with the staff member wearing level 2 PPE. The patient needs to be in their own room with the door closed, and 6 air changes are required after the patient's been in the room doing an aerosol generating procedure, which for us means around about 60 to 90 minutes of the room being vacant. And I feel very encouraged that Brendan feels that many of our patients can be savvy and technically competent using technology. Maybe we've underestimated the capabilities of some of our patients. We've also had a small number of what we've called drive-through CPAP setups, where the patients come to the car park, have the CPAP put into the car, and then John Stradling's kindly set up some educational videos for us to help the patient use the equipment. The staffing input is very light, and this is a real worry that the hands-off approach could leave us giving the patient inadequate education and inadequate engagement with the whole process. And so, John, you asked, should we be doing research? I'm sure that we must work together to make sure that longer term we don't impair the quality of what we're doing. So what on earth are we going to do post-peak? It's an area of tremendous concern. We have over 300 patients waiting for CPAP setup. We have 390 patients who haven't had their sleep study and are waiting to have their sleep study. And whilst we'd like to get on and consult with the patients, we have to fill out breach form paperwork individually. So many of our patients have already had their consultation, and we propose that we will bring in 4 patients at a time to sit in the corners of the room to have group education, not turn the machine on, so the staff member can be in level 1 PPE. If we were to run that Monday to Thursday, 3 lots of 4 per week, Friday and Saturday, 2 lots of 4, we could see up to 64 patients per week and have perhaps some chance of catching up. It's very high throughput. We won't know whether the patients will tolerate the mask, but it's impersonal, and will our staff become fatigued and burnt out? Many of us have been working using CPAP to treat COVID patients in hospital. And so I'm sure this is well known to most of us within this meeting. But it's just to highlight that if any machine is turned on, we need a non-vented mask with a bacterial viral filter and a distal expiratory port, no humidification, single room with the door closed, and ideally negative pressure in the room so the room can be used more quickly afterwards. Level 2 PPE for all staff during and an hour post CPAP use. Care with the order in which the machine is on and off and the mask is on and off. And of course, the same is true for home NIV setup and cough assist setup. Now, whereas we can probably get away with posting out CPAP and the patient doing it themselves at home with video consultation, I suspect that the same is not true for non-invasive ventilation and cough assist, and that the patient probably needs to work with the therapist while settings are titrated. And thank you very much for the question that came in from France to say, well, what are we going to do about titration of CPAP pressures to find the optimal setting? Well, John Stradling carried out a very useful piece of work showing that the 4% dip rate and the neck size were the best predictors of the eventual required fixed CPAP pressure. And that given that there's quite substantial night-to-night variation in pressure requirement, that this little algorithm, which I've highlighted here in red, is very good at determining the pressure required, and that just putting everyone on 10 centimeters of water is marginally inferior to that. So thank you very much, and I'm now going to pass on to Sonia to talk about follow-up. Sonia, are you unmuted?
Oh, stupid, sorry, hi. Hopefully you can hear me. So thank you very much to our previous speakers. So a lot of this has already been discussed before, but what we found on a positive note is that the COVID period allowed us to actually change our pathway at Aintree, which is something we've been trying to do or wanting to do for a while. So prior to the COVID pandemic, our pathway was standard one of face-to-face CPAP setup, and then ideally for a compliance visit, again face-to-face, at around 6 weeks. And that was usually about 6 weeks, up until about 18 months ago, I'd say, when that started creeping up to 8 weeks, 10 weeks, 12 weeks, and eventually we were ending up with a backlog of over 2,000 patients with an average wait time of a year for the first appointment. Now, I don't mean there was no contact between us, between the lab and the patient for a year, but we tend to find that there was ad hoc phone calls to the department wanting help, because there wasn't this face-to-face appointment at the 6 week point. So we've been wanting to move to a more virtual pathway for quite a while, but there was resistance within the organisation at various points, and obviously some view that perhaps patients wouldn't like it, that it wasn't as good for the patients, that the staff didn't particularly want to do that. And obviously COVID has just, as we've already mentioned, just kind of cleared the way to changing to a different pathway. So during the COVID time, because we had staff available and a lot of our secretaries, for instance, helped out with this, we set up a telephone call centre to remove the backlog. And up until yesterday, we'd gone through 1,163 calls to basically go through all of the patients who were waiting for an appointment and triage them into whether they were doing well in the CPAP. And I should add that we have remote monitoring for all of our patients. So we are obviously in a different situation from others perhaps, but we were able to look at whether they'd been using the CPAP machine and have a telephone call and then triage them as to whether they felt they were getting on well, whether there were any problems, and we've documented all of this in detail. And about 23% of those patients that we've called, the 1,100, feel that they're doing well on the CPAP and there don't appear to be any issues in terms of the Epworth Sleepiness Score or any of their symptoms. And about a third of the patients phoned, given the fact that they hadn't been potentially seen for a year and needed consumables. So that was one of the concerns that we had, that there needs to be a more proactive way of getting equipment out to these patients. So we've moved to a new pathway. So that was dealing with the backlog, and we've now moved to a new pathway where patients will be phoned at 48 hours a week and then 6 weeks. So we've got a cohort we were setting up CPAP through the COVID period for patients who we felt were at high risk. And the compliance for that group is 58% versus about 49% with our old method. Now you may say, well, we were setting ourselves up for failure given the fact we had a long wait for compliance. But even looking at back at 2015, where our pathway was running much more successfully, and it was a 6-week follow-up period for face-to-face, the compliance really is no different. So we had, during the COVID period, set up CPAP with no machine turn on for the mask fit. And as I say, it doesn't appear to have affected compliance or how patients are doing when they're phoned at the 48-hour point or the week, and we're now out to 6 weeks. So we really feel that we've wanted to move to that model already, and we will continue with that model moving forwards. And as I say, we do feel that the results of the call centre, it seems to be that patients get on well as long as you have access to new parts and masks. Can I have the next slide, Annabelle? So just to, what we've also done prior to COVID, was look at the results of, we've got about 6,000 patients who are on AirView enabled devices, the remote monitoring. And we looked at a period of between October and January of 2020, but looked back at all of the, rather than just the 3-month period, we were able to access all the remote data for the whole period that the patient had been on the machine. So back to 2015 for some of our older patients. And what we noted is that 50% of patients are fully compliant by the end of week 4, and then remain fully compliant. Whereas, as we all know, non-compliant patients tend to remain non-compliant. Then there's the group in between who seem to lose interest and stop trying. It seems to happen about 18 to 24 months. So they start by not putting on their mask during the day, then they reduce the number of days that they're using it, and then they give up altogether. And that does appear to be impacted as to whether they've got access to masks and equipment. So if you're not contacting your patients adequately or giving them access to getting their equipment, then obviously their compliance falls off. The reason for highlighting it in this era, and the reason I mention it, is just that it's trying to work out who we should be focusing on and what we should be using the phone calls for in terms of remote access group pathway. So really, I think the idea that everyone needs to be brought up for a face-to-face visit obviously is not the ideal in the COVID time, but nor should there been even before this. And we should really focus on these patients who are trying but struggling. And certainly a phone call in the sort of 48 hours, 1 week, 6 weeks, by 6 weeks, certainly you'll know which group the patients are falling into. And actually the non-compliant patients, you may either need to bring them up for a face-to-face, but that's a relatively small group. And it may be that after you've spoken to them on the phone, they just do not want to continue with it and want to use other methods, such as weight loss or lifestyle changes. So it was just to highlight that might be a way of, I know lots of groups are already using this method, but it was just to give some data behind and some that might reassure people that actually a remote monitored virtual pathway does work. And I don't think it necessarily reduces the patient experience, and I don't think it reduces the, in fact, we feel it's actually a better pathway. So it was just some data behind how we've instituted this during the COVID crisis. So that was really the last slide that I had. I think it's over to Annabelle.
Thanks very much, Sonia. I've really put this up as our final slide for discussion. So I think it's really important that we don't just assume that the telephone and video consultations are equivalent. We need to show they're non-inferior, and our only opportunity to do it is before all our centres take up this new practice. And really here up for discussion are a couple of questions. Is remote setup non-inferior to face-to-face setup of CPAP? Is setup without the machine turned on non-inferior to traditional methods of pressures during setup? And Sonia, thank you for sharing your data. That's really encouraging, and potential outcome measures might be our adherence at 3 months, continued use at a year, or perhaps from Sonia's data, we think we need to look at use at 18 or 24 months, and cost and time effectiveness. So thank you very much for allowing the three of us to highlight some practical different options to diagnosis, treatment and follow-up.
Excellent. Thank you very much, Sophie, Sonia and Annabelle. And it is very encouraging to see how you have employed different solutions. I particularly like the comment with Armageddon, but then if it was Armageddon, the panic came a bit too late, Annabelle. Nonetheless, so many questions that come up there. I think just as a comment, as John Riley also suggested, do we need to do studies? Yes, we do need to do studies, because all of this is new evidence and no one has the ultimate wisdom here. We are trying to find solutions, and eventually we need to have evidence-based knowledge to make the right choices. Just to pick up on this, and we are now opening up in the remaining time more and more to answer more questions from the audience. But maybe just to make this first comment towards Annabelle, because of course, in a time where we are shut down and we can't meet face to face with a person, a virtual meeting and guidance, maybe remotely with a mask or so, might be a very suitable option. But about the non-inferiority of this towards an face-to-face review, I might be a little bit old-fashioned here, but something like the swollen legs of the patient who comes and meets us in the clinic room and who might appear suddenly breathless if they walk towards us. Something like these kind of little signs that something else is not quite right might, in my opinion, get lost virtually, because I might look at someone, but they sit, I don't see their feet, I don't get an overview, and these kind of, almost GP checks, they might fall short. And so I'd be very curious to see whether a virtual only service would really be non-inferior compared to a face-to-face interaction. Not the least that I'm a social being and therefore like to talk to my patients in person. However,
I wonder if I could just highlight another disadvantage of a virtual interaction, is that I think we really lose the opportunity for training colleagues, and we really lose the support and input of relatives. This week I saw a patient with their husband and daughter, and what a joy that was. I felt I got a much better understanding of the challenges they faced at home, a much better idea of whether they would cope with their non-invasive ventilation and whether they'd have the dexterity to handle the buttons.
Very good point. So questions now open not only to the speakers but to the whole panel, and I might want to start with a very important comment that I saw from James Oliver posted earlier about PPE and AGP procedures. James made the point that actually the Trust executive team might differ with their opinion about guidance. They don't agree with the position statement from the ARTP or the ERS, for example, and therefore getting the support with the right kind of PPE equipment is difficult in these times. That is maybe something to put out there. What is the panel's experience with being provided with the right PPE? I personally have been redeployed in my trust to support ICU, and therefore did not have trouble with that. We were very well supplied, but I do appreciate that is not the same everywhere. And in now the setting with outpatient clinics, what are the panel's experiences, Sonia, Sophie, and Annabelle, from your larger sleep centers?
I'd like to extend my thanks to the ARTP, because following the publication of the very clear guidance that you wrote, that was a real lever for us to have the appropriate safe PPE within our lung function, sleep and ventilation services.
Good. And this is what it's all about. I mean, we all have maybe brackets of answers, but we don't need to reinvent the wheel. And a lot of these online resources, also thankfully referred to you in your presentations, might be already out there. We just need to become aware where they are. And thus, for everyone who is in today's webinar here, we are intending, thanks to Jill, who is supporting the OSA Alliance, to minute this and to somewhat put a transcript online, so that you don't need to find all this on your own, but that we are all up to date about online resources. Fine. Tim.
Thanks, Jörg. So I've got a question here from Kerry Sutherland, which I think is very relevant. So she's got two questions, so you have to bear with me while I scroll between the two because they're interlinked. We completely suspended our sleep service after lockdown on March the 17th and are now struggling to get it restarted. Any suggestions? And then I think that's preceded by one which is very similar from Kerry. So she says, our trust requires a QIA form, which I take to be some sort of risk assessment business case for restarting a service after COVID, which I'm familiar with at Royal Papworth. That has to be submitted before restarting services. And Kerry says her sleep service is not being prioritized. How does she encourage managers to understand how important the sleep service is? And Sophie's put up her hand, so over to you, Sophie.
So we had a similar scenario that we needed to complete forms if you want face-to-face encounters to happen. But by remodeling your service as a remote service, we really had a green light to carry on. And so for us, that has been the solution. So I think we need to assess whether our remote clinic appointments, remote sleep studies going out, we're offering people an option of remote CPAP. It arrives in a box with instructions versus face-to-face CPAP, and then remote follow-up. Potentially there are some people we will never meet, and there are concerns about that, as you've highlighted, Jörg and Annabelle, about the complexities that you don't pick up. But I think for some patients, maybe the working age population, or people with disabilities that they can't get to hospital easily, or they're at risk, they're shielding, that represents a really good option to stay away from hospital and have that access. So for us, by planning a remote service, we got the green light very quickly, but it's much slower having approval for face-to-face. And you have to, certainly in our trust, you have to say that you'll be socially distanced. The room has to be cleaned between patients. So the numbers you can see in an afternoon are very different to the clinics we were doing beforehand. And I think in terms of restarting, you probably just need to bite the bullet and get going with different strands of starting some phone clinics, starting some remote sleep studies, and starting some remote/optional face-to-face CPAP.
Thanks, Sophie. Adrian, you're putting up your hand there.
Yeah, I just want to echo what Sophie said. We actually effectively have not done any face-to-face clinics. I've been doing all telephone clinics. We're about to go over to video conferencing clinics now. We've got all the equipment. And in terms of NIV, I think we've done 1 or 2 setups where we've dedicated a room specifically because we have poor ventilation, so it's not used for 3 hours afterwards. And that again has been no problems. But for NIV, there are certainly a small number of patients absolutely who do need to come in and be set up. We've done remote CPAP setups, the box as Sophie describes. And just to pick up on one other point that the 3 excellent speakers made, one of the things that we've done for years is to have an email address which we encourage all our patients to use. So if they need new masks, they can email in. If they've got any question, we advise them that no question is stupid. And we do get a lot of email traffic that way, which we can filter out, either the physiologists filter out or it comes up to the consultant practitioners to advise the physiologists on. And that actually has worked very, very well for the majority of patients.
Thanks, Adrian. Sonia.
Just picking up on Adrian's last point, yes, we do have an email address as well, but what we found is that if you leave it up to patients to decide when they need a new mask, can you hear me? That they don't always realise that their mask is failing, and that seems to lead to the poor compliance. So I think we do need some, going forward, I'm sure everyone else has a better structure than we did, but that you do need that structured phone call asking how are you getting on, any problems, actually asking about leak, because patients often struggle and do this kind of thing, through the night. And you can see that in the remote monitoring, that, the multiple times of moving the mask or multiple waking episodes where they're starting to fail, and it's usually about 18 months because they haven't actually asked for a new mask. So you would assume that patients would ask for a new mask, but they don't, they're not always proactive. So if you leave it up to patients to email, it doesn't work, as we've discovered. So I'm sure, as I say, other people have better follow-up than we did, but we've noticed that that really is a problem. But yes, in terms of restarting, we've continued urgent CPAP setup through the period. And as Sophie's already said, just trying to make everything as remote as possible with at least face-to-face seems to be the way forward.
Thanks, Sonia. I think just to add in my thoughts, I think there's so much about OSA diagnostically and treatment-wise that lends itself to remote follow-up. And also our instinct is to solve problems, compromise, accommodate, to try to make things work. And I think sometimes that can work against us. And certainly that when we've been so ready to free up space for others and just get things to work, we go off the radar from management and so on, and we lose even more of our footprint in terms of face-to-face capacity. And I think it sort of feeds a perception that our patients, our condition and our need for face-to-face resources when we need them are not so great as others. So I think there is a risk there as well, which we've got to be careful of. I would certainly echo the thoughts of Jörg and Annabelle about that face-to-face value. So there's still a balance to find, isn't there? But Jörg, over to you for the next question.
Thank you, Tim. And just between all this doom and gloom, reading here between the comments, Alison Macmillan, this is quite an uplifting note. They have moved significantly with the follow-ups into virtual space and do in full PPE their urgent setups, and they, as of today, referral back to normal levels. So please read these comments as they come in. They will remain visible on the Q&A platform. But I want to move on now to the next question, which is now slightly disappearing. John Stradling, what do you think will happen when a patient on CPAP comes in acutely to a hospital with a heart attack? For example, when they need CPAP. So this is for the current period, obviously very important. And I would assume that if they came into an acute unit of critical care, where PPE requirements are full AGP, that wouldn't necessarily be a major issue where I work. But if they are actually on the way and on a peripheral ward, that might be a very different question. Maybe I hand over to some of the former PhDs of John Stradling, who will get that question, of course, right. Sonia or Sophie?
I think Annabelle highlighted this, so I don't know if you want to take this, Annabelle, but the guidance is clear for using CPAP in hospitals with non-vented masks and filters. Annabelle?
So, John, if the patient were admitted to Oxford and they needed cardiac intervention, they would be fantastically lucky because the cardiologists have a wonderful, swanky, all singing, all dancing new building with single rooms. So it would be quite easy for this patient to be able to have their non-vented mask and circuit temporarily in hospital. The staff would need to use level 2 PPE if they attended the patient in the night. And that should be the standard of care wherever they are in the hospital. I think the difficulty is that if the patient is in an area which is the commonest set up for wards in the UK, they'd be in an open bay. And in this, with the current prevalence of COVID-19 in the community, we have to think that that puts patients at risk, and that should not be the standard of care until the rates have gone right down.
Good, thank you. Tim?
Thanks, Jörg. Just scrolling through the questions, so many of them. There was a training question. Well, actually one from Chris Rogers from SATA, which is relevant. As obesity is the main driver of the increase in demand for sleep apnea treatment, is it not about time we made tackling obesity a campaign with the same resources and efforts as the Stop Smoking campaign, thereby reducing what can be for many an avoidable affliction? And I think that also, again, this thing about the telephone clinics and so on, yes, we may have their BMI on a piece of paper, or, well, not a piece of paper, of course, on a letter from the GPs that can help us remember to bring it up in a teleconsult. But when you have the patient in front of you, there's obviously the visual reminder. So it's quite a broad question, quite a policy question, but does anyone, would anyone like to tackle that one?
I'll have a quick go. Absolutely, Chris. I think tackling obesity, we would say, is a priority in healthcare, and resource needs to put into that. And I think that really comes into we mustn't compromise the service we're giving to people by having adapted to the remote one. And in my phone consultations this week, I've been trying to assess people's obesity level over the phone, which is not ideal. And I think it does mean we will not be giving them the same information or access to information to lose weight that we were previously. So I think that is an area that could suffer, and it means we need to link in with the GPs and weight loss services more broadly. But this is an under-resourced area. Obesity is increasing. Absolutely, it needs more work on it. But I'm concerned that will be pushed to one side for a while now because of COVID-19.
Well, following the pandemic lockdown and actually lifestyle changes, more sedentary work, less activity, less leaving the house will have further contributed to exactly that problem. And I completely agree with what has been said. Maybe similar to the action that was taken for smoking cessation, we need to come up with a strategy to tackle this more upfront. It's very difficult to do, of course, and it's not an easy or quick success that can be promised, but that doesn't mean that it's not successful to address obesity. And in the long term, the outcomes are certainly beneficial, considering that high blood pressure, diabetes, potentially sleep apnea is potentially reversible if you address the obesity problem. Fine. Thank you for this. Maybe the next question here from Alex Perkins was addressed to Brendan, but Adrian, if I could address this to you instead, do we need to reconsider the competencies for sleep HSC practitioners / scientist trainees and others, given the shift to all the telehealth models now, the use of video calls, phone and remote monitoring?
Thank you, Alex. I think the answer is that yes, that probably does need to be part of the process. The training that goes on with healthcare scientists in day-to-day practice, I think the centres that are doing things like Attend Anywhere, which we're about to move over to, so that may solve some of our visual issues with not being able to see the larger patient, and how we manage this and the remote monitoring aspects of this. This will all come in to the routine day-to-day practice as we move forward. I think it can be part of the syllabus that is taught to the apprentices and to the STPs who are working in these fields as they develop their skills. But that's more about hands-on than it is so much about the theory behind it. But I think it would be important to show the difference between what is an ideal face-to-face consultation and what happens with either Attend Anywhere or its equivalent, or just telephone consultations. I think the downside, and it'll be the same with medical students and junior doctors who don't come into clinics now because we're not doing face-to-face, we're going to have to find some clever ways of almost creating a fake patient by using perhaps the larger members of staff in our hospitals who may or may not be our patients anyway, and creating teaching videos. And I think that it's not the same, I totally accept that, but it's probably what we need to do over the coming months to the next year to 2 years.
Thank you, Adrian. And actually, online videos, there was also a request, and Sophie referred to one in the presentation. So online resources of educational content are going to be important. Sophie, you've got something to add?
I was just also scrolling through the questions, and there've been a couple on other things we're not assessing remotely, which is tonsils, pharyngeal shape, jaw shape, for which people would do better with mandibular advancement devices. And it's really just to highlight that I agree with those questions. Thanks for bringing it up. We've made huge progress in recent times about recognising the importance of non-CPAP therapies for OSA, and we mustn't lose that ground we've made. And I think that's a key area that we should be just bearing in mind, that we don't want to go back to a CPAP one-size-fits-all when these other therapies may well be more suitable.
And Adrian?
Just to add, Sophie, Annabelle and I all sit on the guideline group. When they do come out, it is likely to mention alternative therapies as part of those guidelines. I use the word likely because we can't say it will yet.
Thank you. Thank you. Tim, over to you.
Thank you, Adrian, for that little hint. We wait with bated breaths. Just some feedback. Hi, Sonia. This is from Charlie Orton. I loved your honest data. Non-compliant patients are always awkward. I'm sure that's meant in the best possible sense. Would you prefer to outsource them to a specialist? Which I think that's what you are anyway. It means a different specialist, but
yeah, presumably he means a third party or another company. I don't know. Yeah, so obviously other companies can take over the follow-up of your patients and take that burden away from your sleep lab. I think we prefer to follow up our own patients. I don't know what other centres do, but what we found is the physiologist who was doing the new pathway found it really nice that she was phoning the patient that she had set up, rather than 6 weeks later getting patients in who she hadn't set up the CPAP. So you're speaking to the patient that you had set up and following them through the pathway, which just gave that personal touch, and also feedback for the physiologist as to whether what they've done is a good setup, and whether they chose the right mask. And in terms of training, I think that's really important for our physiologists, that they're getting that feedback from the patients that you chose the right mask, got the right setting, or no, actually it was far too low for me, or whatever. So I think it is, although we have this backlog and we have this huge problem in sleep labs, I think it's nice that we're following up our own patients and getting that feedback. And say for training purposes, is really important.
Thanks, Sana.
So probably no is the answer.
Jörg.
Thank you, Tim. So plenty of questions still coming in. We've got a couple of minutes left really before our 3 o'clock deadline. Samantha Briscoe actually on the one hand pointed out with a comment that she was very pleased on an uplifting note how her trust and management supported PPE. And then a question from her: we've discussed disinfecting diagnostic oximetry screening devices. What about the CPAP devices on trial in the patient's home for a 2 to 3 weeks period? How do we clean these? Now, maybe Adrian, yes, fantastic. There's a volunteer. Over to you.
So what we have done is any CPAP machine, or indeed any NIV machine that comes back, is effectively quarantined for, I think it's 5 days before we will clean it. So there is a delay. We reprocess CPAP machines normally pre-COVID. We have an area which the machines are bagged, I think double bagged, held in for a period of about 5 days. Then they go into proper cleaning as guided by our infection control team, and then they are re-released back into usage. And I don't think there's any issues in following that procedure. The 5 days allows us for all of the deterioration of the COVID on the various surfaces to probably have been cleared away.
Thank you. And Annabelle, you had another comment to this point? No?
I'm very concerned about this idea of needing to quarantine kit, because we don't quarantine our telephones or mice or desks in the department. And I certainly don't quarantine fruit and veg coming back from the supermarket. So I feel there's a bit of a discrepancy between what we're doing with our sleep kit and what we're doing in our normal life.
Yes, I'm sure we all share your concern about the kind of diverting answers that we get from everyone in these days. But then we cannot deny that CPAP has been declared an AGP, and that's probably unlike your supermarket shopping, I guess. So we must somewhat follow certain guidance. And to be honest, although I personally never really felt at risk, I have recently met many people from the screening wards at King's College Hospital, from the COVID screening wards, and they all have positive antibody test results. So I share the concern that one should be cautious in these days, because if we all, without knowing, have had the contact and have antibodies and might have been unknowingly spreading this, we want to be certain in what we're doing now towards our vulnerable patient cohort and not expose them to any additional risk. I think it was mentioned before with surfaces, 3 days quarantine. I guess the odds are out there, whether it's 5 days, whether it's 3 days. There are certainly not big evidence trials on this, but there is some knowledge on this, of course. Let's be cautious and find our mojo back whilst stepping forward. Before I hand back to Tim for maybe one final comment, just to mention from SATA that there's information leaflets with many informations that are quite useful for the sleep services, and that these leaflets can be requested and sent out to the sleep services across the country. They are supported by the ARTP. So Tim, over to you. We have 3 minutes.
Right, gosh, Jörg, I wasn't expecting another one. Right, okay, so I did see one here. Are there any other methods being explored to drive up patient compliance, such as user support groups, user-provided Q&A vids, or a moderated Reddit sub for UK CPAP? So I'm not sure what that means. Does anyone understand that last bit? No, okay. Oh, Sonia.
Well, I don't understand, I'm afraid, but we're using just a simple guide from a psychologist, a clinical psychologist who was working with us. I'm sure other centres are using this already, but again, just how to get used to your CPAP.
I know that Chris, that we all need the...
I'm trying to get feedback there, but yeah, so it's just really how to get used to your CPAP mask, so a bit to improve adherence. So, you know, just the usual guidance that we would say, you know, put on when you're watching TV, that type of thing. Just a little bit of mindfulness and psychology behind it. So we have got that already available if anyone wants to use that. It's nothing.
Thank you, Sonia.
It might be helpful.
Thank you. I'll have to interrupt you to let Jorg wrap up before we lose our session altogether.
Thank you very much. That brings us after 2 hours to the end of our session, and thanks all the speakers, all the panelists, and particularly the audience for holding out to the end. Certainly a lot of things to learn, still more to come. I think it becomes clear that as a team we function all better, and it's actually quite nice to see each other in person and to discuss these issues. No one has the ultimate knowledge here, and we still have many unanswered questions. It's very uplifting to see that already a lot of services are running again, that there's a lot of ongoing activity, that we are all trying to find our new normal. And we will do our utmost to bring this transcript from this session to you, to share the information and the resources mentioned with you. Jill and Jenny, who is hiding still behind the BSS host logo, thanks so much for helping to organize this and set this up, invite everyone. And I'm sure this won't be the last of our series on the web. We will make more use of these kind of webinars, whether in terms of the OSA Alliance or the BSS in future, to bring content to you. I hope you enjoyed this. I hope you learned something. And if not, then wait for the transcript and get back to us. I'm sure you will get links out either via Twitter or, for example, the BSS or the ARTP web pages in the near future, possibly the BTS, etc. So look out for information, talk to everyone who's been chatting away. And sorry if we didn't find the time to answer your questions. There are still plenty open. We might get back to this when we send out the transcript. I wish you all now a very good weekend and a successful start into the next week of released lockdown. And please all stay safe. Thank you.
Thank you. Take care.
Bye.
Bye.